Hi, Sharon.
Hi, Doc. How is it going over there?
Oh, we're just good. I'm going to, so I have a new system here, but hopefully we'll be able to. I'm just
Okay.
trying to um multi-speaker. Let me see.
Yeah, I'm letting Sunny and I were just texting just now, so I'm letting him know that we're on.
Let me see. I don't know if I'm trying to figure out a way to put the non-speakers because I made you a co-host. So I'm just going to put speaker. I don't know. Sally, I'm going to have her shut her camera off if she can, because I'm going to share PowerPoint. We'll start. We'll just do an update. And I'll just ask people to put their camera down. I thought I could just make co-hosts, but we'll see. Okay. How are you doing?
Oh, yeah, really good. Survived Halloween, so that was that was a big. I have a 9-year-old and a toddler, so
hmm
it was busy.
The We didn't do anything for Halloween. We went out to dinner. We were in Connecticut. So
Wow.
I think when let me see. Let's see. Show I don't know how to undo this. Trying to figure out the view here. Grid. So I'm gonna put her in the waiting. Then I'll be able to figure it out. The So it looks like you're doing a lot of work together and things are um rebooting, which is exciting.
Oh, yeah, I think today might be like the final day of Sun Genomics, so it's like it's being acquired or parts of it part whole. So it's so complicated. I didn't realize that by picking today, it was like picking like a fulcrum, like the day that everything transitions. And so I'm like, okay, well, we'll just
Yep.
stick
You know, the
to.
best laid plans of mice and men, right?
Oh my goodness, right? So it's so funny, but Sunny and I conferred yesterday about, what we wanted to focus on, how we're gonna
Hmm
manage the slides and everything. So that, it's so easy. We've been working together for so many years. So it's kind of seamless. Feels very natural to still, be collaborating. Okay, we got some
Your
people in the.
camera, yeah, and mute your microphone. I will let you free.
And when Sunny joins, is he going to be co-host as
Yeah.
well? I'm thinking, yeah,
hmm
so he can share screen. Great.
Yeah. Let me see. We start in 5 minutes. What time is it? I don't even know what time.
No, 3:56. I mean, sorry, 6:56 your time.
Okay, 4 minutes. Yeah. So I'll just keep an eye out for do they joined. And they were charging me so much for Zoom, and I guess I should explore GoToMeeting.
Oh, probably. Oh,
A
yeah.
lot of
It's
people seem to use that.
right, right, right. Yeah.
I think that's like a Microsoft thing. Here we go. I'm going to put those over there and then I'll add anyone there. And then I have the slides that I'm just going to give a brief update. So right at 7, I'll do that. And then we can move into your presentation. I was talking with Sunny last night about the work we're doing at Intellix DNA, which is pretty exciting
Yeah.
as well. I'm hoping to in mapping, genomic mapping, and then gut mapping as part of a mental health strategy with Benchmark Health that Tom
Okay.
Insel started. And he has a long history and he's raised a lot of money to screen for mental health, but they were only going to refer to Medicare covered services, which is basically another licensed social worker. I'm like, that hasn't been found to be effective.
Wow.
I'm like, if you're going to collect all this data, shouldn't we, build in GI mapping and genomics?
Yeah.
And they were like, oh, is it a covered? And I go, well, no, raise the money to do all we
Yeah.
need is
Yeah.
50 people to prove our outcomes are better.
Jeez.
So it's Sharon and I were kind of like, wow, this is pretty frustrating. But we're working on it. I've reached out to some investors and hoping that we can, you
Oh,
know,
there's Sunny. I'll let Sunny in if that's okay.
okay. Yep, your co-host.
Yeah. I'm like, come on, Sunny. And then the other people you want, let me
I
know when you
will,
want
I'm
to
going
add.
to have them all come on board. I was
You
waiting
got it.
for my office manager to come in for 10 minutes. Mhm. I had to send my secretary out in an ambulance today.
Wow. Tough Tuesday.
Yep, it has been just,
God.
did Sonny come in? Oh, there he
He,
is. Okay.
he is there.
Because I want to make him more. I want to make co-host. Okay, good.
Yeah.
Okay, good. Then I can oh, we have people showing up.
Not sure if we can hear you though, Sunny. Say something.
He's muted.
No, you don't have to mute yourself, Sunny.
Please leave your message.
Mm-hmm. Let me just
Your earbuds working, Sunny?
I'm just going to ask everyone to mute their microphone. So, Brendan, if you can mute your microphone, everybody mute their microphone, otherwise we'll be echoing. So, if you could do cameras and mics off, that'd be great. Just because there's so many people, and I will mute. I will not be muted. But everyone mute. We switched over on Zoom because they divided. I used to be able to do webinars, and then they have a whole new system. You have to buy a webinar. So I was like, all right, let's see how this works. So welcome everybody to our first attempt at a Zoom, and maybe we'll go to meetings. Karen, I need you to mute your mic as well. I guess I can mute all here. Um, Mute all. Okay. I think that's it, except for the host. So I'm going to ask Sunny to unmute, and then Sharon has to unmute, and then we can get started. Add contact, and we're good. There. Sunny, is he offline?
I'm online now,
Oh, well, you are.
Dr.
Okay,
Hopkins.
that's
Yeah,
excellent. All right.
yeah.
Well, welcome everyone to a update at Hopkins Medical Group. I thought Liana was going to be coming on, but right now we're going to get going. So we are on time.
Hi, Dr.
And
Hopkins. I'm actually here.
oh,
I'm so
okay.
sorry. Yeah, sorry.
The so I'm trying to, I don't mean to act stupid about this, but again, I am don't know how this does that. Hide thumbnail, though. I guess that's the best way to do it. I'm going to right now. All right. So to everyone, I just did want to bring you. Liana is here. You're unmuted. Can I make you a co-host, Liana?
I don't see that on my end, but
But I can hear you. So
yes.
that's good. So everyone, we just wanted to bring you up to speed with what's going on at Hopkins Medical Group. And, we are always in staffing rehabilitation, I call it. Many of you have met Liana. She is here this evening to bring us through our staffing and changes. And Liana, I'll let you sort of walk through who we have on desk on front and take these names down so you can say, I need to talk to Will or Fiona or Kayla.
Yes, yes. So welcome everyone. My name is Liana, the office manager for those of you that I haven't spoken to or met yet. So yes, out front, our front lead admin is Fiona. And she also has Kayla working with her. Kayla is doubling as a front admin and then also jumping in as an MA when needed. We also have Will that supports the front end on Thursdays. Um, the clinical staff in the back, we have Allison that's in on Wednesdays as our infusion nurse. She also works for Sweet Life Infusion, who's located on the second floor now. And then also we have Devin that doubles as our MA and our laser tech in as far as our clinical support staff in the back. So that is our staffing at the moment. So if there's anyone that you need to speak with, Allison also takes care of our prior authorizations. Devin takes care of our prescription line. But basically, everyone wears each other's hats here at the office. So if there's anything that you need addressed, you can really speak to anyone. And at the end of the day, I'm your girl. You can come and ask for me, and I will help you with whatever you need.
Can you see the slides?
I can see the slides, yes.
Okay, so I just wanted to go through our clinical staffing providers. So we have a new nurse practitioner, Erica Sampson. She comes to us from Milton Hospital. She's been on the orthopedic service there, basically managing inpatient pre-op and post-op patients. She brings about 20 years of experience, both as a nurse and now as a nurse practitioner. She will be starting, I think, at least 3 to 4 days a week in
Yes.
December. At that time, we bring back Lauren Mushadi, another nurse practitioner who started with us last year. She's been out on maternity leave since July 1st, and we're hoping to have her back in December. Um, Many of you are familiar with Sharon, who's been with us for, I think it's 28 years now.
Mhm.
And she's leaving Harvard University Student Health and will be full-time in January. Many of you know Leslie, now a nurse practitioner who'd been with us over 10 years. She's going to be providing functional medicine coaching, nutritional oversight. She works with our GI mapping and breath test and other GI testing. So she continues to be in the office 2 to 4 days a month. Allison, as we said, is at Sweet Life, and many of our patients are now upstairs for their biologic therapy. We will continue to offer IV therapy in the office, such as Myers, rehydration, IV antibiotics, intravenous steroids for acute flares, and NAD plus, which is noted by Time Magazine to be the biohack of the century. Um, Other updates, I am now the medical director, Novella's Infusion, Weymouth Center. That's at 1121 Main Street. Many of our patients have migrated there, in addition to being at Sweet Life in our current address. LabCorp has moved its office to the second floor. Rachel is up there now. So we have lost her as a fifth arm for a tough IV and a blood draw, but I'm hoping she knows where the elevator is and can help us if we need it.
Right.
Sweet Life is offering services again for our infusions. Athena update. I'll let you take that, Liana, for a few
Yeah, so
minutes
with
since you've been
we
working with
recently had an
Athena.
upgrade to our Athena. EMR system. So now through our patient portals, our patients have the ability to pay their balances online, whether it's copay ahead of time, ahead of your visit, or whatever balances you might have online. You can now also schedule your own appointments with your preferred provider. Dr. Hopkins is our rheumatology provider. And then, as mentioned before, Sharon, Lauren, and Erica are our primary care providers. If you need any help distinguishing which provider you should schedule with, please call the office and we can direct you in that manner. Also, we have opened up ZocDoc for new patient referrals, and new patients are able to book new patient appointments only via the ZocDoc website, which is a great tool for our patients. And unfortunately, starting in the new year, there are some insurances that have some telemedicine, telehealth appointment restrictions, starting with Medicare. And unfortunately, whatever Medicare puts into practice, all major insurances follow shortly after. So as of January 1st, Medicare will stop covering the telemedicine, telehealth appointments. So unfortunately, those patients would have to come in office. And we apologize for that inconvenience. And there's, nothing we can do about that. But we also have and will continue to have same day urgent care appointments. And the great thing about our office is that we have the ability to treat most of um sicknesses as far as UTIs and all your basic needs. But then if you're running that line between emergency room and urgent care, we have the ability to do IV antibiotics and IV hydration, keeping you out of the emergency room and paying those emergency room copays. So that that's what's great about our office. So you just give us a call and we will fit you in with the providers that we have on that day.
So I'm going to go over some exciting changes, well, not exciting, but some changes in cancer screening. So colonoscopies are now dropped down to 45 years as a start date. I was informed by a patient. I actually didn't know that since it's not on my radar for some reason. We do have other options beside colon screening, including Cologuard, and recently we have contracted with Guardant. It is a covered blood test which can screen for colon cancer, but it also screens for many other cancers. Galleria we also use, which is a surveillance blood test for cancer cells for patients that have had cancer or are extremely high risk. The good news for Guardant is actually that they have coverage with most of the major insurers, including Medicare, which is actually pretty amazing. Wish I knew that in February. We are also working with Intellex DNA. This is a genomics company out of Austin, Texas. It's how we build your personalized medicine. We can offer a small snippet, so to speak, of your genome. If you're interested, just depression, anxiety, we can do a full mental health screen. We can then do an executive general wellness. And then we can look, there's then the powerhouse, which scoops all of them together from cognitive decline to depression to risk for ADHD. There's a treasure trove of data that comes out of that. The good news is your genes never change, and your parents won't change. But what'll change is they're now engaging in a new platform which will pull in more databases through AI and make it easier for you then to create a centralized um, database with your genome that'll show you the fixes. And the fixes include everything from lifestyle medicine, the data supporting that, to diet, to pharmaceutical, to nutraceutical, adaptogenics, and herbals. So it's really exciting. I have done it for myself and was able to educate my cardiologist on why I was such a tough hypertensive patient. And really to delineate the risks that I see have inherited from my parents and to then build a supplement base with liamine, citrulline, nitric oxide to maintain your health age, to keep up with your age. So longevity or healthgevity, and all of us are hoping for healthgevity. So I'm just going to, I think I'm at the end of our slides for that presentation. And I want to bring everyone back to our guest this evening. And I'm very excited to bring on board Sunny Jane, who I think, I don't know, we're going back 5 or 6 years at this point, right? From the beginning,
Yeah, it's
first
been an
mentor.
exciting time.
Yes. And Sharon Treadwell, who has been so gracious, who also has worked for years with Dr. Jane on the personalized gut biome. And as all of you are quite aware, that we continue to get enormous amount of data that supports that the gut biome is a participant. So when I meet with the academic centers and they want to institute a new treatment pathway, it's not only what we're doing in a telex DNA, but it's also GI mapping, and they're married together. So I wanted to invite Sunny back and Sharon back to really bring us up to date on the newest data. You know, many of us look at GI mapping as an integral part of our practice. Since we've opened our practice to new patients, I will tell you the 15 to 35-year-old group, I think it's 50, maybe it's 60% have GI issues. They have dysbiosis that leads to constipation, bloating, irritable bowel syndrome, and leaky gut. It's amazing how extensive it is. So I really thought it was time for a full update. And I'm going to bring on that PowerPoint, and we will, let's see, start from there. Here we go. I think I can
And
pull
Doc,
this off. Or I don't know, can you do
D-
it, Penny?
yeah, I actually have an updated one just
Okay.
that I've
All right. So why don't
fixed
you, I'm
some.
going to let you drive the ship and do an introduction so that we all can um, give us your background and how you ended up here and what we have to look forward to.
Fantastic. Thanks, Dr. Hopkins, for having me. And hello, everybody. My name is Sunny Jane, former CEO and founder of Sun Genomics. We were the first company to create and invent the concept of precision probiotics, so a precision medicine approach to natural supplements. And now I'm really focused on the validation of the microbiome, bringing clinical utility of the microbiome, and we're going to chat a little bit through that here today. But before we do, maybe introduce Shireen briefly.
Hi, everyone.
Hi.
Thank you for having me. I'm Shireen Treadwell. I met Sunny all the way back in 2017 when we had to explain what the microbiome was to almost everybody we spoke to. And it's so nice to see it come so far. And that's what we're going to talk about is how far it's come, but in that period of time. And it's really exciting to see what is right around the corner. So take it away, Sunny.
Well, I think the nail on the head there is what's the update, in the microbiome and what's changed. It's the field moves so fast, 20 to 30,000 academic publications per year. In 2016, when we were just starting a company formation, around gut microbiome, there were perhaps 3 to 4 thousand publications. And like Shireen was saying, I think microbiome was like a $10,000 word. And now people are starting to understand, oh, microbiome, that means all the gut microbes in my gut. That means that the composition is important, or if it's off, then it can be dysbiosis. So there's a lot of general knowledge that patients now understand, and they'll be bringing that to their practitioners, and practitioners have become amazingly educated in this space. Dr. Hopkins is one, but she does constantly push the envelope and educate herself on new technologies, and there's still work to go to make it to the general practitioner side. But what we do know, I think, and disagree with me if you want, that gut microbiome is no longer just gut. That is a big turning point. That gut microbiome is not just digestive diseases and digestive conditions. It doesn't mean C. diff. It's, FMT is not the only solution. It's not just E. coli, it's much bigger than that. It is whole system biology at this point, and we're going to talk about some of those areas of weight, mental health, and cognition today.
I just did a brief course on the oral and nasal microbiome with an ear,
Yes.
nose, and throat. My husband's an ear, nose, and throat. And I'm like, I had to wake him up and go, you shouldn't retire. You have a new career here if you learn this. And I think that's the challenge, which is when we do, even now, currently with the companies we work with, we're working with colonic stool. And how does that really reflect what's happening in the small intestine, the oral biome, the esophagus, and the sinuses?
I mean, just imagine if we had capability at point of care when you go in and do those swabs that you're just looking for like streptococcus or staph, or if you're just looking for mycoplasma. But imagine if you could look at whole microbiome, right there in urgent care, you would be able to definitively understand which antibiotic would be the best course of treatment, if any. You would be able to understand different types of pathologies as opposed to these very complex, like algorithmic ways to run multiple tests at once, and then sort of the diagnostic odyssey that comes with it. So
Right.
I can't wait for the day, and I hope your husband does get back
I
on
carry the
the
plague now.
yes, it's because that is actually a big field. I think that's emerging is respiratory and nasal. Just because preventative. I mean, how great would it be to never have a sinus infection because you catch it before it happens?
Hmm.
Yeah.
Whoever has their mic on, I'm going to ask just to make sure everybody's mic is off except for the speaker. That way we don't keep any echo. So thank you. All right,
So
take it
one
away.
It's one of the things that it brings everything to sort of a commonality is the mechanism. And that's where we try to look at, okay, you have these gut microbes. Gut microbes are doing something in our body. They're releasing something into our body. You may have heard the word metabolite. You may have heard of words like short chain fatty acids, butyrate. And so these are molecules that are interacting with our human selves. And we're going to talk a little bit about that one axis of how these short chain fatty acids actually have multiple points of pathways that affect these areas. Then we're going to walk through a little bit on the new mechanisms of action in Alzheimer's. This is a recent study that we'll share here today and published in October that's making us rethink how we look and treat Alzheimer's. We of course will hit on the hot topics of weight loss, GLP-1, and would love to hear from Dr. Hopkins on treating patients with medicines versus some of the natural solutions that have worked, and then maybe open it up in a discussion on just thinking, is there a new paradigm for biomarker testing
And
with
I'll
with
just
the
tell
gut?
everyone, if you have a question, write it into the comment. And when we get, I will try to keep abreast of that. And if there are pertinent questions, I'll read them out so we can all discuss them.
And in addition to this, I think Shireen has a few related areas on mental health and autism that we can talk through as well. And Shireen, you let me know where you think that might best fit, and perhaps right after the first slide, you could share a little bit about the impact in autism spectrum disorder.
Sure. It could also fit very nicely in the new paradigm for biomarker testing. So, since I'll be specifically talking about a biomarker that's a metabolite of microbes. So,
Perfect,
yeah,
perfect. So first, and I apologize if I don't have this full screen. Let me see
It's
if I
full
can.
screen. You
Okay.
could put it on to play, so we're seeing your sides on the slide, but it's not affecting our visual.
Okay. I'm going to leave it so I don't mess anything up.
Sure. Yeah,
It's
right,
working.
exactly. I understand.
So this is the one axis, many phenotypes concept. And the main axis I'm talking about is the production of short chain fatty acids by the microbiome and the gut, and how it can affect major depression and anxiety and neuroinflammation. It has gut brain barrier implications. and then our own gut intestinal tract implications and stimulation of GLP-1 pathways or like or similar pathways. And the interesting about how to produce these short chain fatty acids, it all kind of comes down to one group of nutrients, and it's dietary fibers. Now, there are other ways to produce them as well, polyphenols, and there's other microbes of the gut that also will produce short chain fatty acids. But when doctors and medical professionals and your nutritionists are saying we need more fiber in people's diet, this is probably why. It's not really that, oh, we didn't have enough fiber in our diet, and that's why our human cells are not functioning properly. It's actually this whole second self of our body's cellular mass, our microbiome, the microbes that are living. They need these dietary fibers to secrete these short chain fatty acids, which in turn are the helpful molecules to our human self. And so there's these pathways to GLP-1 and receptors where short chain fatty acids like butyrate interact with, and implications in weight regulation and appetite control, which we'll talk a little bit about that. But what I think is actually some of the newer and really fascinating data is, okay, if you think about the gut epithelial lining, right? It's like this barrier. You eat some food, go down your esophagus. It's now going to go through your stomach, it's getting into the intestinal tract, and now the only thing separating that food or that chyme or that nutrient mixture from inside of your body and passing through your body is this small little cellular layer called the epithelial cell layer. And those cells, in addition to mucin, are a protective barrier that allow and select what molecules should pass through into your bloodstream, into the rest of your body. And as it turns out, when short chain fatty acids go through that intestinal tract, it can stimulate GLP-1 release from these little epithelial cells inside of your epithelial tract. And that mechanism is almost identical to how they're describing the blood-brain barrier today. And that the tight junctions at the blood-brain barrier and the cells that are there are taking signals from these short-chain fatty acids. So we're seeing these common signaling pathways on these barrier components to our human bodies, all driven by molecules that are released from the microbiome. And
So we think the short chain fatty acids participating in the protective barrier for the endothelial cells. So we have many have seen the pictures of the villi, and you have all of
Mhm.
your endothelial cells, but then there's this, I call it like the layer of Vaseline, you don't autolyze your own cells. So there's this, I call it the hotel of bacteria that are doing the work to then send the signal to transmit, so your digestion becomes energy. It's all about energy and transferring uh, molecules from their you're eating a steak, you're having a potato, you're eating an orange. Your mastication is the first place that you introduce bacteria to start breaking down the elements into their elemental factor. And when they come into the small bowel, then they have to go in and transfer into the gut, into the blood cells that are flowing all around the gut. So there's this whole dance that's taking place. And I think one of the big disruptors I've really been cognizant of is how many people are taking um, uh, PPIs uh, and disrupting with protonic pump inhibitors the pH
Yeah.
balance, therefore shifting what's happening in the small gut, so you don't get to the short chain fatty acids that you need.
Yeah, changing the pH. These microbes are without question sensitive to pH. Low pHs is going to be that more acidic environment, but in certain parts of the gut, that's good for bifidobacterium. That's good for these low pH surviving organisms, but it's not as good for maybe some of the Saccharomyces boulardii or some of these healthy eukaryotic or yeast organisms, and perhaps some of the Faecalibacterium or Roseburia as well. They prefer the higher pHs, and um, so if you do have, you know, medications that are changing the ion flow, and then the pHs are beginning to be variable, you can only imagine that's going to create a lot of um, choppiness in the gut microbiome and
Sure.
perhaps dysbiosis. I wonder if they've done that study. Do you know, Dr. Hopkins, if they've looked at?
Um, I don't know if they've done this study. I just know that there's been a lot of research, actually, because I have a number of patients with pouches,
Uh,
that in the short gut with the pH, the Clostridium, the commensal Clostridium, do not do well in the colonic epithelium, and it creates dysbiosis. So we end up treating them with
yeah.
cycles of ciprofloxacin just to keep knocking down the Clostridia. But
Uh,
so keeping that bile pH balance, and oftentimes we end up with a lot of people with digestive problems actually adding bile and HC hydrochloric acid with betaine back into the system because there's data
uh,
that shows low acid production in the stomach actually leads to more reflux because there was an elegant study in Japan where given a PPI, eventually, in not that long a time, we know over 6 weeks, we start to knock down the reflex cycling to the lower esophageal sphincter. So while you're
mm.
not symptomatic, you can still be refluxing the whole time you're on a PPI.
Yeah, that is definitely a nuanced component of overall microbiome, regulation that probably is not generally thought about in the general practitioner world, and so love it that your clinic is considering the microbiome impact here and how to overcome it. That that same mechanism feeds on itself. The short chain fatty acids themselves help the other microbes. So if you have good, healthy short chain fatty acid production from a diverse, healthy commensal bacterial load, reduced pathogen and inflammatory microbe population, then you're going to kind of have a way to modulate and buffer perhaps some of these pH changes as well. But if that is upset through something, environmental factor or medications, then it can kind of be a slippery slope. And that's where we're starting to see more and more people fall into these chronic conditions. I thought this study on the blood-brain barrier that came out in October of 2025 was really fascinating. One, it's controversial a little bit because for the last 20 years, we have been focused on, okay, if you have cognitive decline, you're heading towards Alzheimer's, right? What's creating the cognitive decline? We think it's these molecules, or they call these plaques, that are forming inside of our brain, and we can't get rid of these plaques. They call them amyloid plaques, and we can't get rid of them. If we can target them with medicines, and somehow bind them, then they're no longer active, and we can revert the effects of cognitive decline. But it's been 20 years, and we knew it was coming. The boomer population continuing to age and needing these types of solutions. We were laser focused on that method, and it hasn't really netted therapies that work with high levels of efficacy. It perhaps can delay and buy us some time, which is amazing in itself, uh, but it hasn't had the strong efficacy. In a mouse study that was recently done, and most of our work in this space has been around mouse models, even to get to the point where we are using drugs in humans. This new mouse study thought that, hey, let's look at the blood brain barrier because one of its functions actually is just to be a good filter plate and to be able to look at molecules that shouldn't be on one side of the blood brain barrier versus the other and move them out. And so what they found is that the blood brain barrier actually looked a little bit similar to tight junction formation of epithelial cells. So you see this occludin, claudin 5. These are those molecules that help cells stay together. And if there was healthy short chain fatty acid production on one side of this blood-brain barrier, then these tight junctions were maintained and it was fine. But then they looked at, okay, let's take a look at that, and then let's see the amyloid and this tau plaque protein buildup, and what that means if you take antibiotics or if you do an FMT. And what they found is you could actually see that you could have reduction in the amyloid and tau protein production if you manipulated the microbiome. And that was the first time that they were showing that anyone had manipulated the microbiome to results, without really understanding where the chain of events is. You manipulate the microbiome, and the result is you have a reduction in the amyloid plaque formation. And so this establishes that blood-brain barrier has a critical role in this mechanism, and is now the target for a lot of new drugs, is restoration of the blood-brain barrier instead of sequestering of amyloid plaques.
So they are, I think the new data is implying that the amyloid plaque is a actually supportive or a reparative event. It's kind of like making it your way through a fire. You're going to have scars, but doesn't mean the fire's still there. The fire's passed. So we got to get to the fire first, which is to secure, I know when the blood-brain barrier. Now, we were taught in medical school back in the 70s that was impenetrable. We really felt there's nothing that's going to get through. And now we know, well, it can be as leaky as the leaky gut. So just to clarify for our viewers, FMT, you're referring to fecal microtransfers. So people that have significant dysbiosis, the research they've done is correcting them with FMT. There is now a company, and I've been trying to get this approved for a patient, Vost. I don't know if you know Vost. They actually have a capsular version for fecal microbiome transfer.
Oh, wow.
Yeah,
Um,
Voist,
and
Voyst, I believe
voice.
it is, or Vost. All I know is I can't get it covered. So we're back to doing it your way, the old-fashioned way.
Yeah, it's difficult with some of the emerging technologies. I feel like the technology has kind of outpaced medical adoption. And so now there's like an encyclopedia worth of technology to choose from. And then now we need the clinical professionals to come to an agreement on which ones are going to be the standard of care. And I think it's an exciting, place to be, but we do need to start having
Mhm.
selection of these technologies and integration into the clinical side. And I think that begins with clinical validations, regulatory approvals, and getting through some of the challenges so you can get reimbursement codes. If you can't get reimbursement codes, I can see I don't like it as sort of a researcher side and entrepreneur side. I don't like it that I can't get this amazing technology recommended and utilized. But I appreciate that the validation and the regulatory things are there so that we can scale these types of technologies to hundreds of millions of people instead of in sort of more advanced innovator clinical networks.
So in populations with high dietary fiber, for looking at it from that standpoint, do you see better blood-brain barrier integrity and therefore less cognitive decline, Alzheimer's, dementia? Because I know the dietary fiber in the United States with the highly processed dietary intake is I think the numbers are like less than 3 grams, between 3 and 6 grams of fiber
Mm,
in a day, compared
yeah.
to 30 to 60 grams of fiber a day.
Yeah. Yeah, it is. It's amazing how long we've gone by ignoring fiber, and I use fiber in a very general like way. I'm not talking about like we all need more psyllium husk. We need a multitude of fiber molecules. That includes resistant fibers. So like if you cook white rice and you cool it down, they're building these resistant starches on top of the rice, and this is super healthy for the gut microbiota. And potato starch, resistant potato starch. There are natural fibers in all the green vegetables that we eat that are very diverse and helpful. There's fibers in fruit that we eat that are very helpful, and so when you bring this mixture of fibers together, you get a very powerful fiber load where it could make sense to actually eat 20 grams or 30 grams of fiber in a day because you're eating diverse foods to get
Yeah.
there.
Yeah. You're
Um,
not just a chia seed pet.
Yeah, exactly. Exactly. So I think the study that you're talking about may not have been done yet, but I think it's very interesting because this data is relatively new. This paper came out in October, where we're starting to look at the blood-brain barrier as like the key unlock to solving some of these cognition issues and decline issues. But there have been studies where higher fed fiber diet and reduced incidence of onset of early Alzheimer's and Alzheimer's disease. So that study does exist, and so there is something to the high fiber diet and reduction of cognitive decline, and that's why people are really pushing it. I love this new TikTok wave on there's like fiber loading is now is a thing, similar to protein loading that we did the last decade. I think we're starting to see a little bit of a turn where we're starting to think that, well, fiber could be really helpful, and let's do it in a fun and nutrition way.
Hmm.
And it plays a role in weight loss. And so here's dietary fiber coming in with L cells are like you can get these mouse studies use L cells that are fibroblasts, but they're meant to represent epithelial cells that line your gut. And so you have dietary fiber, and it begins to release the short chain fatty acids like butyrate, and butyrate has direct scientific mechanisms where they're shown it binds to these GLP-1 like receptors on the cells, and so it has this sort of similar to weight loss drugs, receptor agonist of GLP-1 gives you that same type of stimulation. Now this is done in the gut context. Many of these studies are still in the murine models or the mouse models, and so you probably can't overload butyrate and short chain fatty acids to get massive weight loss. But there probably is a way to make sure that you have a healthy level and you're maintaining healthy level of metabolic function and weight loss, and not having challenges through the gut microbiome.
So
Could we
you,
put this into hyperdrive would be an
yeah.
interesting thing.
But I think one of your programs had looked at establishing after we treat patient for a small intestinal bacterial overgrowth is then doing the 6-month program where we have a prebiotic that addresses the deficiencies within your GI map. Um, Inulin is one of the prebiotics. If you want to talk for a minute about prebiotics and probiotics and the difference between those two, because there's a lot of talk about that.
There is, yeah, the symbiotics and even more, and maybe that's a good topic for Shireen to cover, as she does do some recommendations on that front too. If you want to just briefly describe pre, pro, and post.
Yeah, sure thing. I remember walking up to Sonny the first time I walked up to him and I said, is this a pre, but would you consider this food a prebiotic and that food a prebiotic? And he just said, you know, every food you take in is going to be a prebiotic, but just for which bacteria, which yeast. And he was just saying this as he was like typing out emails to, to many different people and working on things. And I just walked away and just had to rethink, but right now when people colloquially talk about prebiotics, they're generally talking about a prebiotic fiber, often a prebiotic fiber supplement. Inulin we recommend, we just mentioned. Psyllium husk was mentioned before, and now we're starting to see other ones like acacia fiber starting to become a little bit more popular, come to the forefront. But really, there's prebiotic fiber in almost any plant food, whether you're talking about legumes, whether or not you're talking about even antioxidants are considered prebiotic in a way that they can actually help beneficial microbes flourish and grow.
So I
But
often
probiotics,
advise patients one way to attack that is to see if you can have 7 different vegetable forms in a day.
wow,
Uh,
that's impressive. If you can do that, yeah.
If you could do that, and I kind of, I go, you don't have to overdo it, but they're all there, whether you're having carrots and zucchini, tomatoes, dairy, potato, rice. I mean, you can get there, meat. So take all of your foods. And unfortunately, I think either over processed or simplifying diets, people get into ruts. They eat the same thing all the time, or they do fast food. Um, for some reason, Chipotle has a green label attached to it. I'm not sure why. I've never eaten there, but people think Chipotle. Well, I got it at Chipotle. I'm like, it's great. Not sure
yeah,
that's going to help you at all.
yeah, good protein content in their food, but it's missing a lot of the fiber for sure. And we got away, and fast food definitely got us into, at least I think, got us into this idea that we can skip salads. Like salads used to be a part of at my dinner table, at least growing up, like you would sit down, you would have salad while you waited either for the rest of the meal to be cooked or before
Mhm.
you served dinner. And at the time, it was explained to me differently. It was explained like, well, you need to, eat this first as a pre-meal and
Mhm.
slow, and you need to digest and chew all your food. And that was what I was practicing. So then when I went to college, I stopped eating salads because that didn't connect with me. That didn't make a lot of
Right.
sense. I would just eat the food, go to class. And then you begin to see what happens digestively, and perhaps that's why some of the younger kids are coming into the clinic now, and we've gotten away from this really nourishing mix of green vegetables that we used to eat as a salad before our meals. And the microbiome has clearly changed my perspective on the importance of a salad. Like if I could have a salad every day, I would do it. It's sometimes difficult, but it is probably one of the healthiest things you can do for your gut if you could just have one salad in a day.
Yes. The other thing I do, written a lot about is fermentation. And getting to fermented foods as part of your regular diet. I started
Yeah.
making my own kombucha 10 years ago when nobody was drinking kombucha. And my husband's like, how long do I have to look at that snotty thing on the counter? I'm like, well, it's commercially available. So for many years we had the big tank there with the mother load on top, but also things that are part of your cultural history, whether it's sauerkraut,
Mhm.
kimchi, natto.
Yep.
Refrigeration wasn't a standard. It still isn't, I think, in a large part of the world that you just are not guaranteed that everything be frozen or refrigerated.
Yep.
And now that I mean, I do a lot of gardening and I do canning and I also freeze all my kale and Swiss chard. So I have it for the winter. I have it all layered in little uh, freeze dried. Well, I don't freeze dry it. I parboil it and then I seal it. So I have my Swiss chard and kale. Um, my herbs. I make ice cube trays filled with all my herbs that I grow. I chop them up and then I
Oh,
make
nice.
herbal salts. So grinding all big, I'll just go in the garden and take like a cups of earth, chop it into my Cuisinart with salt, dry it on in the oven, and then I have jars of my herbal salts. So just being able to, I tell everybody, make small spaces for small gardens, but you can get a
Mm.
lot there, whether you're doing your herbals, but you're actually achieving the energy of food directly from the ground, and you're working with the soil, which is another way to support your biome.
Yeah, I love that. That's definitely a gardening hack tip right there.
Yeah,
So
right.
I appreciate that. That's great. Use the ice cube trays to kind of build
I
that
grew
stuff.
so much garlic. I had an entire, my wheelbarrow was filled. I couldn't move it. That's how much garlic I had. So drying them, hanging them
Yeah.
in the garage, and people, for me, it's fun when people come over. They're like, "What's going on here?" I'm like, "Oh, I'm drying my garlic."
And all these things that we're talking about, like these are the prebiotics. These are the things that are going to drive the beneficial microbes of the gut up, whether it's Bifidobacterium infantis or longum, or it's your Faecalibacteriums or your Rosburias. Without these prebiotics, there really aren't other ways to shift the microbiota in a favorable direction. Now, you can use probiotics directly, which I think Shireen was going to get to. Maybe if you want to chat about what the probiotics are.
Sure. So, I mean, really, I mean, I'm not actually, full disclosure, not a microbiologist. Sunny is. My background is in immunology, cancer immunology, and immunology of infectious disease. So that's where, my expertise, overlaps a little bit.
You love
But
Clostridia.
yeah.
Yeah.
So when you talk about like, all the infections, all the inflammation, and that's where I get really excited. And so, but really the term probiotic is a designation. It's a classification of microbes, be they, bacteria, certain bacteria, certain yeast, and even certain archaea. So, and these are microbes that have been agreed on by the scientific community as more beneficial to us than we are to them. So these are microbes that are naturally found in the environment that we've been living with for thousands of years. We've been eating them, we've been consuming them, and some of them are very, very well adapted to our bodies. And whether it's yogurt, as you mentioned, many different cultures have these fermented foods as part of their history. And so we've been taking these in. And just like Sunny mentioned, going to college, if you stop taking in these fermented foods, if you stop for whatever reason, that has a negative impact on health. So I'm glad we're all kind of looking at them again.
So there's been a lot talk about echinacea being, a GLP stimulator. You see a lot of companies coming out that, oh, this probiotic will stimulate your natural GLP. Because patients are asking me now, okay, I reach my target. Do I have to stay on a GLP-1 or Zepbound, which is tetrapride? Do I have to stay on this forever? And well, there's data suggesting that if your biome is optimized, that you should be able to stimulate GLP-1. What I think I see a real challenge is leptin resistance, and that there's been corruption in the leptin and its receptors. And even if you're making GLP-1, the minute you come off of it, you haven't been able to um, reestablish a natural leptin axis for the metabolism and weight loss so that you're starting to burn calories.
That's really interesting that sort of if you don't use it, you kind of lose it receptor cascade. And
Right.
so you've kind of turned it off for a bit with synthetic pharmaceutical, and it's doing amazing benefit to our bodies, helping with our metabolic health and probably our health span. And but you could grow tired of it, or may not want the side effects, or may not be taking it as often. I believe those studies that say that you can come off of GLP-1s with a healthier microbiome, but I don't know about the consequences of other receptor pathways, and so I think that's really interesting what you're chatting about. and probably worth looking into a little bit more. I haven't looked into that area as it relates to recovery off of GLP-1s, but I have talked to a few clinicians, and they are having a larger and larger client base of patients looking to come, 12 months in, now what? Okay, I feel good. I've lost the weight I wanted. Do I need to continue with injections, or what's the path to wean off? And it's a really good question. I don't know if we've thought about it as a population. What is going to be the standard of care? And doctors are probably the innovators of that program,
Mm.
and what that should be, what that should look like. My
I know
guess
one thing.
is,
What I've tried to, and I just don't see practitioners doing this. I'm not sure why, but even for people with type 2 diabetes, I check a fasting insulin level. I actually do not a glucose tolerance test. I do an insulin tolerance test. So I measure their
oh,
insulin response, and I teach them not to go on insulin and then use herbals like berberine, which act like
yeah,
metformin, and then
yeah,
inositol and vitamin D, because the studies back in 2009 showing that the pancreatic islet cells are dependent on vitamin D in a translation and hormonal mechanism pathway. So I've been able to reverse type 2 diabetes with targeting their receptors
wow.
and increasing their certain minerals and vitamins, and then they've come off insulin. I'm like, no, you have insulin. And they're like, in fact, I have a 86-year-old. She had diabetes and she was going into renal failure. And I said, well, I think the insulin's creating your renal failure. So I'm going to taper you off your insulin. She's like, what? And I said, no, let's see how far we can go. We went from 30 to 20 to 18 to 16, then 15. She's down to 2 units of insulin.
Oh, wow. Yeah,
And
the
her
taper
kidney
is a
function
really,
is
that's a good
normalized.
idea. Yeah, taper and monitoring. I think those are the two key things
Yeah.
that you're providing for the patient care there, that are exceptional. Like we should get that level of personalized care. That would be amazing
Yeah.
if we all could get it, but it's difficult uh, when the recommendations are, well, you should just continue to stay on the medication, or
Yeah.
deal with the weight regain or the
Yeah.
consequences of your metabolic
How
impact.
how do you assess the small bowel microbiome compared to the stool? Because when we're doing GI mapping, we're using the stool, which we know is a different landscape than the small bowel.
Yeah, so technology has changed over time. When this probably first started, I would say it's about 30 years now. We've been have the option for GI mapping at some level. People were using PCR testing, and PCR means that you're just taking a small fragment of the entire organism's genome, just like we have a genome. These microorganisms have genomes. You would just read a small little fragment of that, and you would identify it, and that would be the only way you could assess what's going on in the gut. Well, those genomes and using that PCR method didn't give you a lot of resolution across the intestinal tract.
Hmm.
It was generally kind of focused on the colon, and it took it took quite a bit more work because you want to look at the bifidobacteriums, you want to look at the
Right.
other probiotics and the other um, more aerophilic organisms that might be further up in the intestinal tract, and um, so new technology has come out that allows us to do, with higher levels of sensitivity, analysis using whole genome sequencing. So this is called next generation sequencing. And what's different about it is that instead of amplifying small little fragments of the DNA, they use really bright fluorophores, or binding molecules, and then they extract all of the DNA, and then they bind these fluorophores onto the DNA, and they shine lasers onto those fluorophores, and based off the colors that are coming off of those lasers, they're able to read this alphabet of the DNA, the A, C, G, and T, with extreme sensitivity. So it's not just, okay, I gotta look how many amplified fragments I have, and I only have this UV instrument to look at, how much brightness do I get for this fragment and that organism. You have this really high sensitive, high power laser shining into this microscopic slide off of these NGS sequencers, and that's producing a level of visibility we never had before. And so that's where um, my focus has been on ushering in next generation and whole genome sequencing technology, because it really is the next technology to make it into the clinic. You're already seeing it used in non-invasive prenatal testing, uses NGS technology, which replaced amniocentesis, which used to be a PCR test. You see it in the Galleria tests that you mentioned, and I think Guardant has some level of sequencing
Right.
going on in their assay as well. It's just the visibility that you get with a small amount of sample, what we can analyze as just like amplified to 100x or 1000x objective, right? And if you think of it like a microscope.
So can you see that you would be doing a saliva test to represent the upper and oral biome in a comparison, or can you get a read from the mapping, stool mapping enough to represent the upper
Well, you,
respiratory biome?
Yeah, really good question. I mean, there's studies that already show there's relatedness, so one
Right.
influences the other, but you actually want to know what's going on and if it's something you need to treat or uh, could be potentially bad for you in an infection or gum disease. So you're swallowing those organisms. If
Right.
you have it in your saliva, you're swallowing them. So we would routinely pick up in metagenomic analysis using this sequencing method I was describing. You would pick up native saliva or plaque organisms in the stool. And so they're not common to the stool, but we're finding them in the stool
I see.
because you're swallowing
The
them.
amplification is so great now. Your picture, it's like a spectrometry when we used to go from finding one, would be isolating one molecule and then like, oh, hooray. And
Yeah.
then I had a postdoc that worked for me I used to just sit him down with, okay, just do CGATGT. Sit here,
Yes.
and he'd just go, how long
Yeah.
am I going to be here for? I went, 6 months. Don't worry
Yeah.
about it.
Those are the gel slabs where you had to
Yeah,
read that. Yeah, I remember that.
exactly.
Yeah.
Exactly. That's the old days. I'm dating myself. I'm carbon dating myself. But
So you
so
can
this,
even detect SARS-CoV-2
yeah,
in 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 the gut, and waste management programs across the nation now use NGS sequencing to detect fragments of SARS-CoV-2 that indicate there might be a breakout in their
right.
public health system, in their septic tanks and stuff. And so that's how sensitive it is. It can come down to people swallowing SARS-CoV-2 in their gut,
Yeah.
pooping it out, sorry for the rough language, going into the waste management system into a pool, and you can still pull it out and sequence it and detect it.
I just want to know, when can they check for stupidity? And on that note,
That's a different gene altogether.
yeah,
We haven't made the
I
associations.
want to find the stupid gene. So, anyways, I really want to thank both of you, Sharon and Sunny, for coming on tonight. This is
Pleasure.
recorded. If I remember, I will remember to transcribe it all, and it will be posted on the website. And we just look forward to your research and how you're going to provide us with clinical expertise going forward, and look forward to any working together we can do over the genome and the biome. And very excited to keep you on board after all these years.
No, thank you,
It's
Dr.
great to see you.
Thank you, everyone, and have a good night.